Thank you very much, ladies and gentlemen, and thank you all for coming to this afternoon update session. My name is Ian Bruce. I'm Professor of Rheumatology at the University of Manchester, and my co-chair is Professor David Isenberg from London. I am currently the chair of the SLICC group, and the focus of this meeting today is the contribution of SLICC to research over the last 20 years. It's my great pleasure to introduce Murray Urowitz as our speaker. He's Professor of Medicine at the University of Toronto, and amongst his many achievements, he's internationally recognised as being the first investigator to really describe premature coronary heart disease in lupus patients. I had the great privilege of working with Murray for 2 years in Toronto from 1996 to 1998, and he's a great teacher, mentor and colleague. He's also a co-founder of SLICC, and since I'm too young to remember the founding days of SLICC, I'm going to hand over to my chair, Professor Isenberg, who remembers those days very well.
I'm also almost too young, but sadly I do remember it very clearly. In fact, I first became aware of our speaker today a year or two before I met him. This was at an ACR meeting, and a guy stood up wearing the most brilliant blue blazer you will ever see. And I thought, a man wearing a blazer like that has got to be taken very seriously. And then 2 years, I think it was later, in 1986, as part of the very first International Lupus meeting, which was held in Calgary, there were only about 200, maybe 300 people present. And that was the first time that the BILAG group was going to kind of go public with our ideas about disease activity assessment. And we were placed fortuitously next to probably one of the first international outings for the SLICC system. And a guy called Peter Madison and I were presenting the data for BILAG, and Murray and his good friend and colleague Daphne Gladwin were presenting the data for SLICC. And we kind of got talking as we were standing next to each other. We realized that even though we were coming at the problem in a slightly different way, we had a number of shared interests. And I think it was Daphne who pointed out that it would be sensible to work together and that we might be able to get some funding from NATO, of all people. Though NATO, of course, stands for New Arthritis Treatment Organization. So we got some money from NATO, and we held 2 or 3 meetings, and this was from about 1988 onwards. And then in October 1991, we had an extraordinary meeting of what was then called the NATO group. And we brought in some new people, including Michel Petrie. Murray will probably tell us a little bit about that. But it was actually Murray who came up with the name SLICC. So it's all really down to him in that sense. And slightly to my horror, this was nearly 22 years ago. So it's a great pleasure to welcome Murray, who's going to go through what has happened to us since those foggy days just outside Boston in 1991.
Well, ladies and gentlemen, thank you very much for coming. It's the end of a long day. I know you've all been through a lot, and it's a great pleasure for me to address you. I'm addressing you on behalf of the SLICC group that David has described for you, and to tell you a little bit about our work over the last 20 odd years. Did we make this work on both? Can you see both screens, or does the... Yes, good, we did it. Thank you. So, the SLICC group, if we can make this work. Can't this go backwards? Or do I have to do it here? Yes. Okay, no problem. So the SLICC group is comprised of 36 full-time members in 31 centers in 11 countries, and you see them here. And there we are, in fact, live people. We are a group. There's David, so the UK, John Hanley, the past president, who's Canada. We have Sweden, we have United States, we have Spain, we have Sweden again, and so we are in fact an international cohort of investigators. So in terms of the background, Dave has already told you a little bit about this. We originated back in '86. We got this new arthritis treaty organization that David talked about, grant, in 1987. We were competing with all the military organizations. The meetings initially were held to test and compare our activity indices You heard there's been a friendly rivalry between SLICC and BILAG now for many years. We developed the damage index together, and then we investigated the utility of the SF-36 to do patient-related quality of life. So working together, we've really been able to collaborate on a number of research initiatives, and I'm really proud to say that the group has been extremely productive. We have 32 publications between 1989 and 2000, and we have 7 publications between 2011 and the present time in the past 2 years, and they are in very good, high-quality arthritis journals. So we not only have fun together, we actually produce something. So in 2000, we started this new initiative. We decided to set up a large inception cohort of patients. The initial goal was to study long-term outcomes of atherosclerosis and lupus and to look at the risk factors associated with atherosclerosis. But this new inception cohort became a very valuable resource for us to investigate a number of different issues. And I want to touch on 5 areas where we've had some important information that came out of this cohort study and review them for you. And in each case, I want to try and stress how have these findings affected clinical practice. Research is important if it has implications on how we look after our patients, and I'll try and point that out to you at each point. So atherosclerosis, how the disease evolves over the first number of years, specifically some nervous system disease, and I'll show you the principal investigators for each of these areas, the role of malignancy in lupus, and finally our new SLICC ACR revised criteria for the classification of patients with lupus. Now, in this inception cohort, who are these patients that I'm going to be talking about? They enter the registry within 15 months of their diagnosis, so early in the disease. We follow them at yearly intervals according to a standard protocol, and the protocol includes the demographic features, the disease characteristics, the classic risk factors for coronary artery disease, which is what we were interested in initially, and we also document the coronary artery disease events. So you see there's enough data there for us to address a number of important issues. We also collect biologic specimens, including DNA, serum, and plasma at enrollment and also at each annual visit. So we have a phenomenal resource of biologic materials to correlate with our clinical data. So the cohort as of today, includes 1,837 patients, followed, as I've explained to you. We're 88% female. You can see that we are truly an international multi-ethnic cohort with 50% Caucasian, and then 17% black, and almost 14% Asian, etc. The mean age at diagnosis is about 34 years. Their enrollment, their disease duration at enrollment is only 5.6 months. So these are truly early patients just diagnosed with lupus. So other demographic features, 61% have had post-secondary education. You can see 45% are still single. And their ACR criteria count, and I'll tell you a little bit more about this later, on acceptance into the cohort was 5. So let me tell you what we have on these patients. The maximum year of follow-up now is 13 years. Our mean available follow-up is 4.5 years, and the median is 4 years. The number of patients who have had more than 5 years of follow-up is 852, and the number with more than 8 years of follow-up is 398. So there are enough patients here followed for a long enough period of time to make some valuable observations. So I want to talk to you, as I said, about 5 areas. In the area of atherosclerosis and evolution of disease burden, I've been fortunate enough to be the principal investigator. For nervous system disease, John Hanley, who I see is in the audience, has been our principal investigator, and I'm going to describe all of these findings for you. Malignancy has been a significant issue for us, and we have 3 investigators here, Sasha Bernansky, Ann Clark, and Roz Ramsey-Goldman. And finally, the revised classification criteria, where Michelle Petrie has been our principal lead investigator. So, let's talk about atherosclerosis for a moment. The objective of this overall study to start with was to examine factors at an inception that were predictive for atherosclerotic vascular events over a period of 12 years of follow-up in this multi-center international inception cohort. This is the last evaluation in this area that we looked at. So our definition of events, so events recorded are congestive failure, myocardial infarction, transient ischemic attack, stroke, angina, and intermittent claudication. The important thing here is for us to attribute these outcomes appropriately. If we're going to make any conclusions or predictions about atherosclerosis, we have to make sure that we're dealing with atherosclerotic events and not the other mimickers like active lupus or thrombotic events. So attribution to atherosclerosis is made by the physicians on the basis of the lupus being inactive at the time of the event, and or the presence of typical atherosclerotic changes on imaging or pathology, and or evidence of atherosclerosis elsewhere. So we felt pretty confident when we actually diagnosed an atherosclerotic event that we were in fact dealing with an atherosclerotic event. So the cohort characteristics when we did this study when there were 1,401 patients because we wanted to make sure that we had some degree of follow-up. 90% were female. The usual mean age was 35, and the distribution of ethnicities was as I originally described to you. Now, at this first follow-up, there were 31 patients that had 41 atherosclerotic vascular events after enrollment. And the mean time to the first atherosclerotic vascular event, or the last follow-up if they didn't have it, was 5 years. And you can see the events were myocardial infarction and angina, and one patient had both, congestive failure, peripheral vascular disease, stroke, transient ischemic attack, and the necessity for a pacemaker insertion. So, the atherosclerotic risk factors at enrollment. Now look, at enrollment, you see the classic atherosclerotic risk factors, the Framingham risk factor, diabetes, smoking, obesity, hypertension, not hypercholesterolemia at inception, but increased serum creatinine, were all increased in those patients that had an event compared to those patients that didn't have events. So these are factors that were there and factors that we, in fact, expected. Now, when we did a predictive analysis, in other words, time to the first atherosclerotic event, again, we found what we thought we would find. That is, if you were older, if you were Caucasian, this may have been a bit of a surprise. If you were male, if you had a high Framingham risk factor score, if you smoked, if you were obese, or if you had hypertension, you were more likely to get an atherosclerotic event. So then we did a multivariate analysis because the univariates confirmed what we suspected, but we had to see the interaction term here. And in the multivariate analysis, you see only age and male gender were significant. So they subsumed everything else. So this is the factors that were predictive for the first atherosclerotic event after only 10 years of follow-up were maleness and age. So there's an issue here. How come all those other factors aren't yet operative? So are the results due to the fact that we only had a small number of atherosclerotic events? In order to do a multivariate analysis, you have to have enough power to detect more than 2 variables. So maybe it's too early. We don't have enough events yet. Or is this due to multicollinearity between age and gender and other risk factors? That is, older men have more risk factors. And in the short term, atherosclerotic events are more likely to occur in older men. So to address that question, we did a nested case control where we matched people who had an event with people who didn't have an event 3-to-1 on age and sex. So we took age and sex out of the equation to see if any of the other factors then emerged. And what did we find? In the univariate analysis, again, you can see that if we matched for age and sex, and look, we matched very well for age, we matched very well for sex, the other risk factors were not significant, even matching for age and sex. And so when we did this as a univariate analysis, no significance. And when we did, of course, a multivariate analysis, if this wasn't significant, the multivariate would not be significant, and it was not significant. So what did we learn here? Only age and sex remain significant risk factors for atherosclerotic events in a multivariate analysis of this multi-center inception cohort that were followed for a mean of 5 years. The mean was 5 years. That's the clue. In the first 5 years, classic risk factors have not yet had their clinical impact. And because atherosclerotic events, as we've shown previously in other cohorts, generally occur after 8 years, atherosclerotic events still can be expected, and the risk factors should still be treated. And as we follow these patients over the next number of years, we expect to see the appropriate risk factors that we all expect. And this is only the atherosclerotic risk factors. It has not looked at the disease-related risk factors. So then were these atherosclerotic vascular events influenced by race, ethnicity, or geography? And we wanted to look at that. Well, if you look at where people came from, the region, either Asia, Europe, Mexico, United States, or Canada, or by ethnicity, Asian, Black, Hispanic, and Caucasian, and you can see that some of the ethnicities would come from multiple geographic areas. When we looked at that, you can see that it appears that Caucasians, as I suggested before, tend to have more atherosclerotic events than non-Caucasians. Okay? And when you do this multivariate analysis now, you see that Caucasian is no longer significant. The other ethnicities, and as we said before, the other risk factors are not significant. The only significant things remain age and diagnosis. So we've now ruled out atherosclerotic risk factors, we've ruled out ethnicity and geography risk factors, we're left with age and sex. So in a small cohort of patients with AV for 5 years, neither race, ethnicity, nor geography, or classic atherosclerotic risk factors can predict subsequent atherosclerotic events. All right, we have a ways to go there. We have the cohort, we're going to have the follow-up, and as more events occur, as they certainly will, we'll be able to correlate with risk factors further. The second issue I wanted to address with you was the evolution of disease burden over time. So to do this, we wanted to describe in this cohort of patients the annual occurrence of disease activity, disease damage, accrual of autoantibodies, and to see whether then there is any racial or ethnic variation in this accrual of disease manifestations. So here you can see we're looking at SLICC, so a measure of disease activity in all the patients at year 0 down to year 5. And you can see over the 5 years we're successful in lowering disease activity from almost 6 to 3 1/3 over the 5-year period. A good sign, right? But we haven't made it 0. In 5 years, there's still some measure of disease activity. And if you look at the ethnicity, you can see the same thing happens in whites. The same thing happens to a lesser degree in non-whites and non-Caucasians. And you can see at each year, the Caucasian population, white population, has a lower disease activity than the non-white population. So the non-white population has remained more active over this. They have decreased their activity, but they have remained more active than the Caucasian population over that 5-year period. And this is depicted here. Both decrease, the non-Caucasian and the Caucasian, but the non-Caucasian always have more disease activity. Well, when you look at the damage index, you can see in all patients, the damage index over the 5 years goes up. So it starts at 0.17 and it reaches 1 at 5 years. And you can see that in patients who started out with a damage index greater than 1, you can see that over 5 years they increase significantly, the numbers. And you can see that the white population increased their damage index, the non-white increased their damage index, and here there was no difference. So that in the white population, even though their disease activity came down, their damage increased to the same extent as the non-white population. When you look at antibody accumulation, you can see that when we started off, only 94% of patients had a positive ANA. It rose to 97% at 5 years. Anti-DNA antibody also increased from 29% to 55%. So don't expect at year 1 that what you see is what you're going to get. People progressively increase over that 5-year period. You can see anticardiolipin also increased slightly, but lupus anticoagulant increased significantly more. So you have to keep an eye out for this. And lupus anticoagulant, as I'll show you later, is perhaps the more important of those antibodies. So, what have we learned? What's the contribution to clinical practice here? Disease activity in newly diagnosed patients is brought under control relatively quickly and remains low over the first 5 years. But despite that, damage increases over this period of time. Whites have a lower disease activity as compared to non-whites in the first 5 years. The ANA and the anti-DNA antibodies increase over the first 5 years. And the anticardiolipin antibody, and especially the lupus anticoagulant, increases over that 5-year period. So in practice, just because you got a negative lupus anticoagulant in year 1 or 2 does not mean you should not look for it at years 3, 4, and 5. It's an important antibody, and in some patients occurs somewhat later. Well, then we wanted to look at the ACR criteria accrual over this 5-year period. In other words, do lupus patients come in with what they're going to have, or do things happen over the first 5 years of their illness? So we had 768 patients who had been followed for a minimum of 5 years. And those are the patients that we looked at. And just look at the bottom line here. In these 700 and odd patients, when they first came in, they had a mean number of criteria of 5. And I told you that in the beginning when I described the cohort. But at the end of 5 years, they had accumulated at least 1 more criterion, so that they had 6 criteria. So new things happen over the first 5 years of the disease. And you can see, if you look at it, that both non-Caucasians and Caucasians accrue criteria, although the non-Caucasians had more criteria over this period of time. And if you look at the non-Caucasians, as especially the Hispanics and the Asians, which contribute to that increased number of criteria over the first 5 years. You could see also that females had more criteria than males, and they accrued their criteria. They both accrued criteria, but the females remained had an increased number over the full 5-year period, although and this is statistically significant. So what's the contribution to our practices? Over a 5-year period, you accumulate extra ACR criteria. And the distribution of criteria at inception and over 5 years is affected by gender and by ethnicity. So at enrollment, non-Caucasians had a higher number of ACR criteria than Caucasians. The total number of criteria increased in both groups, but they increased more among the Caucasians. Hispanics had a higher number of ACR criteria over the entire 5-year period, and males tended to have a slightly lower number of criteria compared to females. So that is sort of a description of what happens to the disease activity over 5 years. Well, let me talk to you for a moment now about some of our important findings in the nervous system, neuropsychiatric lupus, led by, as I said, by John Hanley. So first of all, John wanted to determine what was the incidence and the characteristics and the attribution of neuropsychiatric events at the time of diagnosis. So you all know about the neuropsychiatric syndromes classified by the American College of Rheumatology. Now, I have ambivalent feelings about this, because when the ACR came up with these criteria, they were not attributed criteria. These are all the possible neurologic things that could happen in patients with lupus, not necessarily related to lupus. And many people have in the recent years said, oh, this is what lupus patients get. It's not exactly what lupus patients get, and I thank John for working and trying to clarify for us which of these were in fact lupus patients, lupus-related neuropsychiatric events. So his first study looked at the 572 inception patients recruited from 21 centers, and 28% had at least one neuropsychiatric event. Remember, neuropsychiatric event means one of those ACR nomenclature events. And here is a breakdown of what they were, and you can see headache is extremely common, and we know that most headaches are not related to lupus, but these are the neuropsychiatric events. So you had headaches, mood disorders, seizures, other mood disorders, etc. So, I said to you that the important thing here are going to be attribution rules. In other words, how can we be sure that those events that we've described are related to lupus, right? And so there are certain decision rules which were derived to determine the attribution of these events during the period of follow-up. And there are a number of factors that are considered in this. I'm just going to summarize briefly. So one is, when did the event occur? If the event occurred well before the lupus of diagnosis, it would make it less likely. The presence of certain concurrent non-lupus factors had to be considered as a likely cause or a significant cause, such as antiphospholipid antibody syndrome. Now the question is that related to lupus or is it not related to lupus? And then there are a number of other syndromes which are clearly not related to lupus when they occur. The occurrence of minor neuropsychiatric events, things like anxiety, mild headaches, mild depression, mild cognitive impairment, that is less likely to be attributed to an acute lupus neuropsychiatric event, as opposed to the severe headache which requires narcotic analgesia. And when you looked at all of these attribution characteristics, it resulted in two attribution models. Model A, and this is done by Ainala. There is a Model A where we can say this is more stringent and it's more likely that these events are related to lupus. And Model B is, well, maybe they're related, but possibly they're not related. So a less stringent criteria. Okay, so back to John's findings. So here are the neuropsychiatric events that were attributed to lupus using either model. Okay, so in Model A, very stringent, 19% of patients had a neuropsychiatric event. If you were much more lax in your attribution model, it could be up to 38%. So you see, depending on your attribution model, the frequency of these neuropsychiatric events will be lower or higher. And this is demonstrated here in all of the neuropsychiatric events. If you took out those that occurred very early, those that were related to other factors, and you removed all of those, in Model A, in the very strict interpretation of the 242 events, only 46 were attributed to lupus. And if you did it by Model B, it would be up to 93 events attributed to lupus. So you have to be very careful here. If you're going to talk about neuropsychiatric lupus, make sure you look carefully into the attribution of the condition. So only a minority of all the neuropsychiatric events in lupus patients can be attributed to lupus itself. So that's the contribution to clinical practice. Take the ACR classification of neuropsychiatric events with a grain of salt. Look carefully at attribution. Seizure disorders. So John wanted to describe the frequency and the attribution, the outcome, and predictors of seizures in lupus. And so he broke the seizures down into various types of seizures you can see here in the left column. And if these are all the seizures, regardless of whether we attribute them to lupus or not. But when we attribute them by the two models, very strict, not so strict, of the 15 seizures total, of the 15 complex seizures, only 12 would be due to lupus, clearly, 13 if you use the less strict model, and 2 not due to lupus. And this is true for virtually any variety of seizure. You see in the generalized seizures, of the 60 generalized seizures, only 39 were attributed to lupus by the most stringent model. And in terms of recovery, of response, of resolution of the seizures, the interesting feature he found is that if you took the seizures definitely related to lupus, Model A, the red line, their resolution was the best. So if you have to have a seizure, it's better that it be due to lupus because that's going to resolve. The seizures due to other things resolved less satisfactorily than those that were definitely due to lupus. So, what's the contribution to our clinical practice? Seizures occurred in this instance, I didn't show it to you, close to the diagnosis of lupus, especially in patients with African race or ethnicity, lower educational status, and a higher cumulative organ damage. Most seizures resolved without negative impact. And here again, you've heard this anti-malarial story over and over again. Anti-malarial drugs were associated with a protective effect. Why aren't all of our patients on antimalarials? So then he wanted to look at our autoantibodies, useful as biomarkers or predictors of neuropsychiatric events, and he looked at this in the large portion of our inception cohort in over 1,000 patients, and he looked at these antibodies: lupus anticoagulant, anti-cardiolipin antibody, anti-beta-2 glycoprotein 1, anti-ribosomal P, and anti-NR2. And what did he find? Two significant findings: that the lupus anticoagulant was associated with stroke or sinus thrombosis. So this is something that you might expect, and it wasn't true for anti-cardiolipin antibody, but the lupus anticoagulant is a significant predictor of stroke. And psychosis was predicted by anti-ribosomal P antibody. So of the antibodies looked for, 2 were predictors of neuropsychiatric events in patients with lupus. And in terms of the time to event, you can see that if you were lupus anticoagulant positive, you developed the stroke much more quickly than if you were negative. And similarly, if you had anti-ribosomal P, you developed the psychosis more quickly than those who did not have anti-ribosomal P. So, contribution to our practice: in recently diagnosed patients with lupus, the lupus anticoagulant is associated with future risk of intracranial thrombosis, and anti-ribosomal P is associated with lupus psychosis. So it's important to do the antibodies at inception. Now I come to a very important issue for us, and a very interesting issue, and that's the whole issue of malignancy. And as I told you, this initiative is led by Dr. and Clark by Dr. Roz Ramsey Goldman and Dr. Sasha Bernatsky. They looked at malignancies in the SLICC cohort, and they also brought in other cohorts to enhance the numbers, because with malignancy, obviously, we have to have large numbers of patients followed. So when they took the SLICC cohort and all associated cohorts, and I'll show you those in a while, they were able to get almost 16,000 patients and almost 120,000 patient years of follow-up. And again, 90% female, and there were 28 international centers. And you can see we had younger patients, middle-aged patients, not so middle-aged patients, and we had lots of follow-up in each of those patient groups. And these are the groups. There was not only the SLICC group, but it was patients from elsewhere in North America and elsewhere from Europe, in addition to the SLICC patients. A real international study. And here's the bottom line for you. The expected numbers of malignancy in this tremendous number of patients was 561. The observed number was 641. And the standardized incidence ratio of 1.14 was statistically significant. So malignancy was more common in the lupus patients. But what was that driven by? It was driven by the hematologic malignancies. Look, all the hematologic malignancies had a standardized incidence ratio of 3. Remember, I told you the overall incidence ratio previously was just over 1. But when you got the hematologic malignancies, it was over 3. And of the hematologic malignancies, if you took non-Hodgkin's lymphoma, the standardized incidence ratio is over 4. And if in leukemia, it's 1.76. So the hematologic malignancies, in large part, are driving the increased malignancy ratio, incidence in patients with lupus. Now, if you look at this is fascinating, and I'll come back to it in a moment. There were 3 malignancies that were less common in lupus. And what were they? They are exactly the opposite of what we'd expect. This is a female disease. Yet the malignancies less often seen in lupus patients were breast, uterus, and ovary, and I'll show you later, in addition, prostate. So the hormonal associated organs seem to be protective for malignancy, not predisposing to malignancy. You see here that vulva was increased, and this may in fact be due to HPV virus infection in these patients. Okay, so in addition, if you look at the other malignancies, there was a slight increase in thyroid and in lung. So thyroid and lung a little bit, hematologic malignancies a lot. And that's what drives the increased malignancy in patients with lupus. And if you look at the demographics here, if you take the lymphomas and those patients that were cancer-free, you look at the age at entry in the clinic, 7 years, not greatly different. Female incidence, not greatly different. Whites, not greatly different. As lupus duration, SLICC at entry, and Sjogren's syndrome, not significantly different. Not a clue here as to what might be the predisposing factors. And when you have drug exposure, again, you see, I'll show you in a moment the predictive factors, but there isn't a great difference here in terms of the drugs used between those who developed lymphomas and those who didn't. As a matter of fact, with azathioprine, less patients were on with lymphoma were on azathioprine than were that had no lymphoma. Now, when you do an adjusted hazard ratio, looking for predictive factors for all lymphomas, you can see that male gender and age, is this a recurring theme? Male gender and age were predictive of lymphoma. If I've highlighted cyclophosphamide here because it's very close, but it's not statistically significant. The confidence intervals overlap 1, right? So that we don't yet have a clear-cut predictor of lymphomas in patients with lupus. Even Sjogren's syndrome was not statistically significant with the confidence intervals overlapping 1. Now, what about this decreased cancer risk that I talked to you about? Breast, uterus, ovary, and prostate. How can we explain that? So the question is there a hormonal factor here that's favoring the lupus patient? For instance, patients with lupus get menopause earlier, maybe 4 or 5 years earlier than their age and sex match controls. So maybe they're getting less total estrogen over their lifetime. Or maybe they're less likely to get hormone replacement therapy postmenopausal because we're worried about precipitating active lupus, right? So that may be true, but the decreased risk the decreased risk that's seen in SLE is evident both pre and postmenopausal lupus. So I don't think it's estrogen exposure. Could it be genetic? Maybe the genetic profile that gives you lupus protects against certain cancers? Unclear. There's some very exciting data that I don't want to go into now, but that Roz Ramsey-Golden presented to the SLICC group yesterday, that anti-DNA antibody may actually be protective. So you get lupus, you get that terrible antibody giving you lupus, but it may actually protect you against female organ malignancy. That's still in the very early phases, and there are a number of basic scientists looking into that. But this is an intriguing finding decreased malignancy in hormonal-associated organs. So what's the contribution to clinical practice? Results, we've defined that cancer is increased, but the major part of that increase is in the leukemia lymphoma group, especially non-Hodgkin's lymphoma. And there's also this intriguing finding of a lesser risk of several hormone-sensitive cancers, such as breast, ovary, and uterus. Okay, finally, let me finish with you now the revised classification criteria for the classification of patients with lupus. So why do we need to do this? Why did we even embark on this issue? And I must really commend Michelle Petrie as our lead charge on this issue. Well, since 1982, since the ACR criteria were last developed, a number of things have happened. We have an improved understanding of some organ manifestations. The cutaneous manifestations are much better described now, and the neurologic manifestations have certainly been amplified. We have better measuring techniques, so we know how to measure protein more accurately. We have more sophisticated subtyping of autoantibodies, especially the antiphospholipid antibodies, so we could expand in that area. Complement, now we realize, is a very important finding, low complements, and that doesn't appear in the 1982 criteria. And then many people have been saying, I don't care how many criteria you have, if you have lupus nephritis on biopsy and you have a positive ANA, that's enough for me to diagnose lupus. So the issue of lupus nephritis as a standalone is something that we have to deal with. So there were a number of reasons which drove Michelle and the group to look at newer classification criteria. So we didn't just embark on this. You know, Michelle did some very thorough research as to how this should be done. And, you know, Jim Fries, a number of years ago, gave us a number of guidelines for people who want to develop criteria, gold standards. And so what were his suggestions? The first thing is that the gold standard for new criteria have to be established by highly experienced clinicians. So we thought, okay, the SLICC group is a group who have been dealing with lupus cohorts for a long time. Maybe we're the appropriate group to do that. The second thing is, you can't be selective here. You have to do consecutively treated patients from multiple institutions to minimize selection bias. You can't let one investigator bring in all of his or her patients. This has to be from many different sources. And then you have to have controls to say these are lupus, but they're not dermatomyositis, they're not undifferentiated connective tissue disease, etc. So the control populations have to be chosen to actually represent a broad spectrum of diseases that could be confused with systemic lupus. And then you have to define everything you're looking at in the criteria with very strict precision so that everybody is looking for the same thing. And once you've done all of that, and that takes a year or two, then you got to do the whole thing again in a new cohort of patients. These are in a second cohort, a verification cohort of patients. Now, those are tall orders, but to say in Michelle's defense and in her accolade, these were all followed. So, in the derivation set, the first group of patients, don't worry about the details, I'm just going to quickly go over some with you. We chose a relevant set of variables and obtained patient scenarios, 716 scenarios from 25 sites. And these were consecutive lupus patients and their controls. And when we looked at the controls, we looked at rheumatoid arthritis, myositis, we looked at chronic cutaneous lupus, we looked at undifferentiated connective tissue disease, vasculitis, etc., as you see here. We had to arrive at a consensus diagnosis for each patient, and the initial ratings were done by the clinicians from the centers. That gave us an 80% concordance, and the last 14% were reviewed by an expert panel of the experts. Sat down and went over that. And then we identified a reduced set of variables to consider the classification rule, and these were a subset of the experts of the subset of the experts. This took a long time, perhaps almost 2 years to do this, to get down to the final derivation set. And then by doing a number of statistical manipulations, using recursive partitioning, etc., we developed a relatively simple classification rule. And then at the final meeting, these were all looked at, and a number of modifications were made, and the data set was approved. So once we had all of that, we said, oh no, here we go again. If we're going to follow freeze, we're going to have to validate all of this. So the validation set was set with a new set of 690 patients from 13 centers, and we sent off for this serum and plasma to get the antibodies. We arrived at consensus. We did a number of statistical manipulations, and we arrived at a new set of classification criteria. In general, and I'm going to show you this new set now, a patient is classified as having lupus if the patient has 4 of the criteria, which has to include at least 1 clinical and 1 immunologic criterion, or the patient has biopsy-proven lupus nephritis with either an anti-nuclear antibody or anti-DNA antibody. So that special circumstance I told you about came up here. So you have 2 ways of being diagnosed with classified as lupus: 4 criteria, at least 1 clinical and 1 lab, and or 1 criterion lupus biopsy proven with an ANA or an anti-DNA. And what are the criteria? Now, you can't assimilate them all. This is now recently, in the last 2 months, published, so it's available for you. But just to highlight some areas for you. You remember in the old criterion, it was a malar rash or a discoid rash. That's very restrictive. Now look what you have. You have acute and subacute cutaneous lupus, and you have here a number of different kinds of acute lupus that you could have, or subacute cutaneous lupus in its different appearances. So you're not restricted to a malar rash. It's one of the classic lupus rashes here. Or chronic cutaneous lupus, and you're not restricted only to discoid, but there are a number of ways that chronic cutaneous can present, and they're all here. So in terms of cutaneous lupus, it's more easily to be included as a patient with lupus now. Oral ulcers, you see here, are in the palate, the buccal, the tongue, or the nasal mucous membrane ulcers. And all of these are in the absence of other causes. All of these are not attributed to anything else. Then you have non-scarring alopecia, a very important criterion here. So an outcome of patient with lupus, non-scarring alopecia. Synovitis, and here it's arthritis, and again it's 2 or more joints. Serositis, which is either pleurisy or pericarditis. Renal disease is either a urine protein creatinine ratio of more than 500 milligrams or red blood cell CAS, a very important finding. Neurologic now, rather than just headache and visual symptoms, you have and seizures and psychosis, we have a number of other mononeuritis multiplex, myelitis, peripheral or cranial neuropathy, and then the confusional states or neurocognitive abnormalities. In terms of the hematologic or the laboratory tests, we have hematologic, hemolytic anemia, leukopenia or lymphopenia or thrombocytopenia. And then with the immunologic criteria, we have an ANA, an anti-DNA antibody, anti-phospholipid antibody and its subtypes, which now includes anti-cardiolipin and anti-beta-2 glycoprotein. And then now we have low complement, a very important criterion which is not present, and then a direct Coombs test. Now, in the initial derivation sample, when we compared that sample with the ACR criteria, you can see that the ACR criteria had a sensitivity of 86% and a specificity of 93%. The SLICC criteria had a sensitivity of 94% and a sensitivity of a specificity of 92%. So you see the SLICC criteria included more patients that experienced rheumatologists felt clearly had lupus, right? And so it included them, and it lost almost nothing in sensitivity. So a much better showing. In terms of the verification cohort, you can see again the sensitivity went up significantly over the ACR criteria. The specificity went down a little bit, but what we gained in the sensitivity we thought was extremely important. We didn't want to miss patients with lupus because it's patients with lupus that we treat early that we're going to have a good result on. So, contribution to clinical practice, the new classification criteria retain the goal of simplicity of use, easy to add up. They're more consistent with what we now understand in terms of lupus pathogenesis because we include complement, we include all the new skin manifestations, etc. And because of all of those things, they have face validity. They're more in line with what we understand and believe today. So, what have we learned? What have we contributed? I've shown you that we've contributed something in terms of how we understand atherosclerotic vascular disease, how the disease evolves over the first 5 years, and we hope over the next number of years we'll show you how it evolves over the first 10 years. I've shown you some interesting neuropsychiatric involvements and their association with specific antibodies. I've told you about some very interesting malignancy issues, the lymphoma issue on the one hand, and the protective gynecologic organ system on the other hand. And I've introduced you to our new SLICC classification criteria for lupus. It's really been a privilege to work with this group. It's been a privilege for me to present the data to you today, and I thank you very much.
Thank you very much for a wonderful talk. Does anybody have any questions? If so, please come to the microphone and identify yourself.
I have a question. Question? Over here?
Yep.
Thank you. And I hate to bring this up because I know attribution in neuropsychiatric lupus is very difficult, so it's hard to argue with some of this. But just as a sample of someone you might see would be a 15-year-old girl who has a terrible headache and is, perhaps mentally not quite right. You think she might have psychosis. You order ribosomal P. Unfortunately, its incidence is very, very low. Some say 1%. So someone may tell you, well, they can't have lupus as a cause of their psychosis because they don't have ribosomal P. Young people, many times when they get severe headaches with lupus, you do a spinal tap and they have pseudotumor cerebri. I'm surprised that you've thrown out demyelinating syndrome, which in a young person, you can't say that's from microvascular disease. You haven't mentioned neuropsychiatric testing. And this is just accumulation of maybe 2 years of reading this stuff. And I know the wonderful work John Henley does, but I see these patients, and I think it bothers me sometimes that I think it's gotten so finely tuned that the tools that we do have, MRI, spinal tap, sophisticated neuropsychiatric testing, you haven't mentioned.
That's correct, because these are not diagnostic criteria, these are classification criteria, and not everybody gets MRIs and spinal taps to investigate a patient. These classification criteria don't stop you as a clinician to do further investigation.
But I know for a fact from the
and I didn't say that anti-ribosomal P was 100% associated. I said it was a predictive factor. So more likely than not to be associated with psychosis, but not present in everybody with psychosis.
But if it's negative, that wouldn't mean that their psychosis cannot be from lupus.
Absolutely correct. No predictive factor was ever said to be 100%.
And I think as most of us know who have practiced medicine for a long time, unfortunately, a lot of people use criteria for diagnosis.
Right.
And I'm just saying that I'm afraid this may lead to the underdiagnosis.
Okay, fair comments, but I could say if you're using it as a diagnosis, don't limit yourself to this because you have access to other investigative modalities that you can add to this to make a diagnosis.
Okay. Is there any other questions before we finish? Okay, well then, if not, it just leaves me to thank you very much for your attention and have a nice time in Buenos Aires.